All right. Then very high. One more topic is acute liver failure. Okay. So acute liver failure. There is a classic triad of acute liver failure. What do you think? Liver is
Mhm.
failing. Then what would be the triad?
Jaundice.
Okay.
So first you have hyperbilirubinemia, so you can
Okay.
have those symptoms.
Mm-hmm.
Um, then thrombocytopenia, maybe, or
Okay.
reduced platelet.
Yes, very good. So synthetic function is gone. So one is synthetic liver dysfunction indicated by INR more than 1.5. Then
Yeah.
what other things do you think can be in the triad?
Mhm. It's acute, so bile is not excreted, so that's jaundice.
Okay, jaundice is there then. No, you are good. You are trying well. Think.
Then
The amino transferases will be what?
will be raised.
Raised, right?
Oh,
Acute
yeah.
liver
Oh,
failure.
that was the one that there were more than 1,000.
More than 1,000. Okay, this here is going to be raised, but the I think you're talking about shock liver, where they are more than like they can touch even 10,000.
Oh, okay.
Yeah,
Yeah.
but you are right. This is one where it's going to be around 1,000, more than 1,000.
Yeah.
Yeah, that's very very
Yes.
high. But there is something called shock liver where it's going to be very high, around 10,000. It can go that high.
Okay.
But we'll talk about that. Okay, so amino transfer is high, and what is the third thing?
Mm. The estrogen?
Hepatic. Hepatic encephalopathy.
Oh, okay. Yeah,
Yeah,
makes sense. Yeah.
because of all the ammonia. So confusion, hysterexis, all those things will be there. So this is the classic triad of acute liver failure, synthetic liver dysfunction, INR high, aminotransferases, and hepatic encephalopathy. All right.
Okay.
What are the
Yeah.
causes of acute liver failure? What do you think? What can cause
Uh,
liver failure?
any drugs? Maybe drug.
Super, very good. Number one is drug toxicity, and that too, none other than our favorite acetaminophen.
Yeah.
Okay, majority questions are going to be on the acetaminophen toxicity that causes acute liver failure. And
Mm.
concurrently, if a patient has consumed alcohol along with this acetaminophen, it's just going to worsen the scenario. So always
Yeah.
maybe sometimes they will be like attended a party or something and had alcohol. So that's just going to cause more acute liver failure.
What?
Other causes can be
Yeah.
viral hepatitis.
Mm-hmm.
So all the viral hepatitis A, B, D, E can cause this except C. C, remember, C only causes chronic liver failure, not acute. Okay. So one of the options they will like to give along with acetaminophen is hepatitis C. And now you are confused that you even viral hepatitis can cause acute liver failure and
Yeah.
acetaminophen can also cause it. Only exception is C. C never causes it. That is why they have given it in the option. Okay. It only
Yeah.
causes chronic.
Okay.
All right, so it can cause
Yeah.
cirrhosis. This chronic liver failure, so it can cause cirrhosis. So C will cause cirrhosis and chronic liver failure, not acute. Then other causes
Yeah.
can be autoimmune hepatitis, Wilson, blah blah blah, Budkierin, all those things. But main is acetaminophen.
Yeah.
All right, presentation is like you said, jaundice, pruritus, upper quadrant pain, fatigue, and those things. And the diagnostic triad is this: ASTLT more than
Okay.
1,000, confusion, and INR more than 1.5.
Okay.
Clear?
Yes.
All right. Then we have ischemic hepatopathy, which is other name for shock liver. So this is the one that I'm talking about. Here, the main giveaway thing is, of course, the AST, ALT are so high.
Yeah.
They can even touch 10,000. They are very high. But giveaway thing is today, for example, it can be given like this, that today a patient came and the LFTs were normal. Tomorrow, when I did the LFTs, now they are this rocket high. So within a day, if a patient has this such high increase in this AST-ALT, that is nothing but shock liver, always.
Okay.
Rapid in a day and massive increase in the aminotransferases is shock liver. Clear?
Yeah.
All right.
Yeah,
So
makes sense.
most commonly there can be any infection in the body. For example, a patient came with complaint of pneumonia, and I run all the tests today, and I can just see leukocytosis and infection, basically inflammation. Nothing significant. And again, I repeat the blood test today because the situation is not improving, and I see that suddenly the liver enzymes are so high. So the answer is ischemic hepatopathy. Okay.
Okay.
Other options that can get you confusing is alcoholic liver disease or autoimmune hepatitis. Alcoholic is never the answer because you know the AST-ALT ratio, right? And it is rarely more than 300. It is like maximum is 200, 300, not more than that. The AST.
Yeah. So
Yeah.
more than 10,000 is shock.
This is, yeah, crazy. Like 7,000, 8,000 also kind of anything. You know that 5,000 is also very, very high, right?
Yeah.
Yeah. So
10,000.
yeah, this was one question where they had given, I think, around 10,000, but extremely high AST-ALT, that is this.
Okay.
Okay.
Yeah.
Then coming to liver problems, starting with the
Yeah.
most common one that we have been doing, that is cirrhosis. Okay. Now, cirrhosis. First of all, let's brush up a few basic things. Liver has mainly three functions, right? One, two, three. First function is synthetic. Production of all the clotting factors, cholesterol, proteins, that is all by liver. Number two is metabolic. Metabolism of the drugs, steroids, including like detoxification, all those is by liver. And last is excretory. Excretion of bile is done by liver. So if there is any problem in the
Yeah.
liver, there is going to be deficiency in the clotting factors, proteins, the drugs are not going to get cleared, so the levels are going to increase in the body, and bile excretion is not happening, right?
Yeah.
What are the
Yes.
most common causes of cirrhosis? What do you think?
It could be alcohol,
Very
like
good.
the
Alcohol and liver
non-alcoholic.
disease. Very
Um.
good. First is second is alcohol. Non-alcoholic fatty liver disease is so common in United States. It's very
Yeah.
common.
Everywhere.
Everybody, I think now that I'm seeing so many patients, I think I might start having a robot. I never, you never know. I mean, it's so common.
No, hopefully not.
No, hopefully not. Yeah. Then
And then
most
hepatitis.
common cause is what? Yes, exactly. Most common is hepatitis. Yeah.
Yeah.
Hepatitis B, C, viral infections. So hepatitis, alcohol, non-alcoholic fatty liver disease, then like so and so, then we'll keep on having hemochromatosis, biliary cirrhosis, alpha-1 antitrypsin deficiency, cardiac cirrhosis, blah, 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 blah. Main is the
Yeah.
common ones, which is hepatitis, alcohol, non-alcoholic fatty liver disease, right?
Yeah.
Questions would be on the patient. Cirrhosis questions are actually very easy. They will give you questions like signs and symptoms. So now main three problems, like I said, three main problems. One is hepatic synthetic dysfunction. So patient coming with ecchymosis, bleeding, all that because of the clotting factor deficiency. So that is one.
Yeah.
Another very high yield and lot of questions is hyperestrenism.
Yeah.
Liver actually causes metabolism of all the estrogen, okay, via the cytochrome P450. So that metabolic function is not working, so the estrogen is not getting metabolized, and hence lot of estrogen in
Yeah.
the body. Increased estrogen is hyperestrenism.
Okay.
Usually estrogen gets metabolized by liver by cytochrome P450. But if liver is not working, then all the estrogen gets increased in the body, and then because of the hyperestrenism, you will have five things which is very important. Two of them are very important. One is spider angiomata.
Mm-hmm.
Another is palmar erythema.
Mm.
Then other things because of high estrogen that you already know, gynecomastia in a male patient, gynecomastia, loss of pubic hair, and testicular atrophy. That is easy, so nobody is interested in that. The questions are,
Yeah.
all the options are given. The patient has cirrhosis, you know that, and the question would be, what from the following has similar mechanism of like pathophysio as spine angiomata, which is already given in the question. Wow, amazing.
Okay.
So the answer would be palmar erythema, because both spider angiomata and palmar erythema is because of the vasodilation which is caused by estrogen.
Okay.
And yeah, this thing is not helping us. Can you hear me?
Yeah, I can hear you.
Can you see the page?
Yes.
Perfect. Okay. So if they ask what is similar pathophysio like spider angiomata, then the answer is palmar erythema or vice versa.
Yeah.
And they all fall under the category of hyperestrenism.
Okay.
Okay. And last is the portal
Yeah.
hypertension. Portal hypertension we know only. Now, portal hypertension presentation will be esophageal varices, ascites, splenomegaly, all those things. So again, they are not interested in that. They know that you know. Another
Okay.
question for cirrhosis, which is important, is all cirrhosis patient, all cirrhotic patients must undergo, all cirrhosis patient must undergo surveillance ultrasonography every 6 months. Every 6 months, that is high yield. To exclude any liver masses, whatever the cause is, we don't care how the cirrhosis is happening or whatever is causing the ascites, but always you have to, they have to get screened every 6 months with USG to rule out any liver tumor, liver mass. Okay,
Okay.
so USG every 6 months, that is high yield screening. And even
I
if a
can't
patient
see what
has, yeah,
I can't see what you're writing anymore. Sorry.
no, why are you saying sorry?
I can see till the testicular atrophy.
Okay. All right. Fingers crossed. Can you see it now?
Mm, not yet. Yeah, I see it now.
You can see it. Portal hypertension.
Yeah.
Perfect. So USG every 6 months. And also, if a patient now has suddenly has new onset ascites, okay, then all the cirrhosis signs and symptoms are there, but it is new onset, then you have to think of hepatocellular carcinoma, because that can be one thing that is blocking the portal or the hepatic ducts and causes this ascites and cirrhosis like signs and symptoms. Okay, that is why you always keep a check every 6 months. Clear?
Yeah.
Perfect. Another high yield thing about the ascitic fluid is the ascitic fluid characteristics. So number one, the most easy thing about the characteristics is the color. Okay, if the color of
Yeah.
the fluid is bloody, means it is malignancy. Simple thing. Bloody is something severe, so that is malignancy, or of course a trauma, something hit and then bleeding, but malignancy.
Yeah.
If it is milky, means it is pancreatic, milky, or they can also write serosanguinous.
Yeah.
That is pancreatic cause. If it is turbid, means it is infection. And lastly, if it is straw colored, means something related to liver, or right now we are doing cirrhosis, so let's write cirrhosis. Something benign, but liver problem, most commonly cirrhosis. Okay, so easy up
Okay.
till now. Bloody,
Yeah.
malignancy, milky, pancreas, turbid, infection, and
Okay.
straw colored liver.
Yeah.
Okay.
Yeah.
Another easy thing is the neutrophils. Neutrophils in the ascitic fluid. If the neutrophils are high, which is more than 250, means there is infection, simple peritonitis.
Yeah.
If it is less than 250, means there is no peritonitis, so that is easy. Okay.
Yes.
Tricky ones start here, which is the total protein. Okay, so there is a trick to remember this. Total protein, it can be more than 2.5 or less than 2.5. More than 2.5 means there is lot of protein in the ascitic fluid. Less than 2.5 means there is low protein in the ascitic fluid. If there is low protein, means it is getting leaked out of the body somehow, right? So you
Yeah.
know two conditions where there is leakage of protein. One is cirrhosis, all the osses condition where the protein gets leaked, and nephrosis.
Yeah.
Yeah. So all the osses, there is protein leak, so the protein is going to be low. Whatever remains is going to be high protein.
Mm-hmm.
Just remember these two. Whatever is remaining from the options, that is going to be high protein, like cardiac causes, which is congestive heart failure, constrictive pericarditis. So remember heart in more than this protein.
Yeah.
Then peritoneal carcinomatosis, so malignancy, pancreatic ascites,
Mm-hmm.
Budd-Chiari. If you can remember stuff, it is good. If you cannot, then don't worry. Just don't forget this. Low protein is osses, and high protein is the remaining cardiac,
Exactly.
pancreas, infections like let me write two infections, TB, fungal.
Mm-hmm.
Only if you can remember. Okay. So
Okay.
clear about protein.
Yes.
Okay. Another one is SAAG, which is serum to ascitic albumin gradient. Serum to ascitic fluid albumin gradient.
Okay.
Okay. So if that is more than 1.1 or that is less than 1.1. If it is more than 1.1, more than or equal to, means there is portal hypertension. This is serum to ascitic fluid albumin gradient. So if it is more than 1.1 means from the liver, because there is portal hypertension, the protein is getting, albumin is getting leaked out, right?
Yeah.
Okay. So
Yes.
there it is more in the serum. That is why the ratio is going more than 1.1. So causes are again cirrhosis and cardiac ascites and
Okay.
Budd-Chiari. Conditions where the portal hypertension is high. So Budd-Chiari. Cirrhosis, cardiac ascites, and Budd-Chiari are the conditions where there is going to be blockage and increased portal hypertension. Budd-Chiari, where there is blockage and increased portal hypertension. Less than
Okay.
1.1 means there is no portal hypertension. So no portal remaining things. I just remember like this. I remember one thing in both of this, and then whatever remains
Yeah.
is the opposite. So TB, the peritoneal carcinomatosis, malignancy, pancreatic ascites, and nephrotic syndrome. They have no
Okay.
relation with the portal tract, so they are not going to cause portal hypertension. Only these three have relation with portal tract, so portal hypertension.
Okay.
Cirrhosis, you know why it is going to cause portal hypertension, right? Cardiac
Yeah.
ascites because of the backflow. The heart is not pumping backflow.
Yeah.
Right heart failure.
Yeah.
Again, backflow to the liver, and hence portal hypertension. And Budd-Chiari again,
Same
thromboembolism
thing.
in the portal tract. So portal hypertension, right?
Yeah. Okay.
Okay. Now, can you quickly tell me in what conditions do you have total protein more than 2.5, less than 2.5?
So less than 2.5 was the leakage of protein, so cirrhosis or nephrotic syndrome.
Very good.
And then more than 2.5 were all the rest ones, the cardiac, heart
Hmm.
failure, pericarditis, pancreatitis, TB, Budd-Chiari, or any malignancy, all the other ones.
Hmm. Hmm.
Fungal.
Hmm.
Yeah.
Very good. Then this SAAG.
So SA is serum to albumin, so serum to ascites. So more than 1.1 was the cirrhosis, heart heart failure, or Budd-Chiari. And
Hmm.
then less than 1.1 was there's no portal hypertension, so the other ones such as uh, malignancy, TB, or pancreatic, or nephrotic.
Superb, superb. Good with it now?
Yeah, it makes sense when you explain it.
Yeah. Okay.
Yeah.
So you got it, right?
Yeah.
Okay, perfect.
Okay.
Okay, I'm just checking one thing.
Yeah.
Okay. All right. Then coming to, I was just checking something, but it's not that high yield, so we are just skipping it. Okay, esophageal varices. Very, very high yield.
Yeah.
Okay. So esophageal varices, main thing is how would you manage a patient with suspected variceal hemorrhage? The patient had esophageal varices. Now you suspect that there is hemorrhage. They are hypotensive, right? And they have been a long-term cirrhosis patient.
Yeah.
So number one thing is start volume resuscitation in them. Yeah. Number two
Yeah.
is give IV octreotide, which is high yield you would IV octreotide. Okay. And number three is give antibiotics. But there is one more thing in the volume resuscitation. Do you know if there is anything like significant, specific?
Mm. Is it with normal saline?
No, not the fluid, but there always has to be two large bore IV
Oh,
needles. Yeah.
yeah. Yeah.
Because there are questions where they have like, okay, one large bore IV needle is
Yeah.
kept, octreotide is started, antibiotic started, what else to do? And then in one of the options there would be start one more, like give one more IV. So always two. Yeah.
Okay.
And octreotide. Okay, now after you have done the basic things, then within first 12 hours, that is ideal, within first 12 hours you want to go for urgent endoscopic therapy for the esophageal varices. And urgent endoscopic therapy means what? That you are going in with a scope and either you are doing band ligation or you are doing sclerotherapy. But anyways, whatever you want to do, it should be done within 12 hours. That is the ideal time. In 12 hours, urgent endoscopic approach. Endoscopically, you go in, you cause band ligation, or you do sclerotherapy. That is up to you. Clear?
Yeah.
Okay. Once that is done, then there can be three outcomes of this process. Number one, okay, I just went in with the endoscope, did a band ligation. Now there is no bleeding. Bleeding has stopped. Then you initiate the secondary prophylaxis, which is start them on beta blocker, very, very high. Start them on beta blocker plus endoscopic band ligation again 1 to 2 weeks after.
Okay.
Clear?
Yeah.
So after urgent endoscopic therapy, no bleeding, then secondary prophylaxis, high yield is the beta blocker. You have to start beta blocker, but don't give it in primary prophylaxis. It is secondary prophylaxis. First, the thing is octreotide and band ligation, endoscopic urgent band ligation. Okay.
Yeah.
Because in primary prophylaxis also they'll give you, in one of the options they'll give you a beta blocker and then you'll just get excited, oh, beta blocker, go for it. But it is secondary prophylaxis, not primary.
Okay.
All right. Second thing is there can be still continuous bleeding, right? It did not stop after the endoscopic intervention. It did not stop. Then for them, you have to do something to temporarily stop the bleeding, right? So you'll go for balloon tamponade. Right now, just create a compression over there that can stop the bleeding. It is just temporary. Once the after that it is stabilized, then you have to do tips or shunt surgery. Okay.
Yeah. Okay.
And last is early rebleeding. Right now, I just did that endoscopic approach and the bleeding stopped. But again, in like a few minutes, in half an hour, it started rebleeding quickly. So repeat the same because that did work the first time. So let's repeat the same thing. Repeat the endoscopic therapy. And after doing that also, there is still bleeding, recurrent hemorrhage. Then you have to directly go for tips or shunt surgery. Okay?
Yeah.
All right.
Okay, makes sense.
Tell me the management.
Okay. So if you suspect somebody to have the variceal bleed, you'll give them IV octreotide,
Mm-hmm.
then fluid resuscitation with 2 large needles,
Mm-hmm.
and antibiotics.
Super.
Then after that, you would do urgent endoscopic therapy, such as bad ligation or sclerotherapy.
Mm-hmm.
Then you can have three outcomes. If there's no bleeding, you start them on beta blockers and repeat the band ligation in 2 weeks.
Mm-hmm.
If there's still bleeding, you do the balloon tamponade to stop it for temporarily, and then you do TIPS or shunt surgery. And
Very
then
good.
if you've done it and there's early bleeding,
Very good.
then you'll repeat the endoscopic procedure. If that doesn't work, then you do TIPS.
Very good. Super. Got it?
Yeah.
Perfect. Perfect. All right. Okay. Then we have spontaneous bacterial peritonitis.
Yeah.
Why this is given over here? Because it is very commonly SBP, very commonly is superimposed on cirrhosis. Very, very common.
Yeah.
Okay. So first of all, cirrhosis patient, they would never have fever. Cirrhosis patient mostly are hypothermic. They are normally hypothermic. But now, if a patient with all the cirrhosis signs and symptoms is coming to you with either very, very high fever or very, very low body temperature, means there is some kind of crazy septic infection, right? So most commonly,
Yeah.
first presentation is fever, hyperthermia.
Yeah.
No, no,
It was going so well.
I know. Oh, wait, it's loading. Oh God, I better clear everything. Okay, can you see it now?
Yes. No.
Can you see what
Yeah. No.
is written over here?
Yeah.
Okay, so spontaneous bacterial peritonitis. Always, if the patient has cirrhosis, they normally should be hypothermic, and if these cirrhosis patient have high fever or suddenly have encephalopathy, altered mental status signs and symptoms, then you always have to think that there can be spontaneous bacterial peritonitis underneath. And when you check the paracentesis, you check the diagnostic test of the ascitic fluid, the PMNs that we just studied a few minutes ago are going to be high because there is proper infection. Protein, can you tell me what will be the protein and what will be the
Yeah.
SAAG? Hmm?
So the protein will be high.
Why?
No, it's cirrhosis. It's if it's imposed on cirrhosis, then it would be
Hmm.
low.
Super, very good. It's imposed on cirrhosis, right? So protein is going
Yeah.
to be low. And what
Low.
about SAG?
SAG will be more than 1.1.
Very good. Okay. So that is the diagnostic criteria that will be given in the question, and the answer is
Yeah.
spontaneous bacterial peritonitis. Okay.
Yeah. Yeah.
Treatment is start them on empiric antibiotics like third generation cephalosporins and or fluoroquinolones. Yeah, those things.
Antibiotics.
Antibiotics. Yes.
Yeah.
Okay.
Yes.
All right. Most common infections are going to be gram-negative infections, E. coli, Klebsiella, all those things. But majority questions are on what is this, and it is spontaneous bacterial peritonitis superimposed on cirrhosis, because majority symptoms of cirrhosis will be given, and subtly this is given or this is given. Okay.
Yeah. Makes sense.
Okay. Then we is a three major actually. Yeah. Ray syndrome. You remember what is Ray syndrome?
Yeah. Is that when they take aspirin after
Yes.
um yeah, anytime
So
they take aspirin, I think?
very good. So
After
most
viral
common, very good. Most common cause is use of aspirin. Yeah.
yeah.
So they will give you, they will not directly write in the question that the patient took aspirin, right? That's an easy giveaway. So most commonly they'll give you things like there is vomiting and confusion after recovery from a viral illness where the patient took some over the counter medication. But you should know that viral illness and over the counter means the parents most commonly might have
Well,
given aspirin
yeah.
thinking that it's an NSAID and something to help with the fever or whatever. Any reason they have given over the counter medication named aspirin, and now the patient presents with clinical features like confusion, vomiting, increased, jaundice because of the liver damage. So, main two problems in Ray syndrome is the acute liver failure and encephalopathy. Because of the encephalopathy, you have this confusion and everything, and acute liver failure. So the labs are going to show increased transaminases, increased PTINR. I told you what is a triad of liver failure?
Yeah, it was encephalopathy, increased my trans increased
Yes.
transferase and coagulopathy.
Yes, very good. So increased transaminases is one, increased INR more than 1.5. So
Yeah,
PT,
was
increased
it
PT, INR, PTT, right? And
more than
last is the encephalopathy, which is because of the increased ammonia levels.
yeah.
So a child, after taking aspirin, going in acute liver failure, coming to you with confusion and stuff, you should know it is Ray syndrome, and they must have given aspirin. So in this question that I'm talking about, where they had given that viral illness and over-the-counter medication, question was what to do next, or what would you check? Now, right now that we have discussed, and we know it's aspirin, but in that question, the answer line is check medication history. So you will know this only if you can connect the dots and remember that Ray syndrome is something that can have CNS problems and that can have something relation with the viral illness.
Okay.
Okay, because in the question they are not going to give you Ray syndrome, they are not going to give the word aspirin. Both these are not given. But you know that there is acute liver failure in a child and there is a history of viral illness and some medication. So let's check that medication thoroughly and then see.
Okay.
Make sense?
Yeah.
All right. Then we have, yeah, one topic is easy. This is alcoholic hepatitis, but there is nothing crazy. Like I just mentioned, alcoholic hepatitis. What is the AST-ALT ratio?
So it's more than 2.
Right. Every time we have ALT more than AST, one condition where it's reverse is alcohol. Yeah.
Yeah. Yeah.
And yeah, that is the main thing. So most commonly the question is everything is given, and then what? I don't know, but answer line is this usually that check the social history thoroughly, pointing towards alcohol basically. When nothing is given and
Okay.
AST is more than ALT, then check the social history.
Okay.
Makes sense, right?
Yeah.
Okay, important is this one, which is very common, is non-alcoholic fatty liver disease. As the word suggests, everything is in the title. Not alcohol, but fat is causing this liver disease. So patient
Yeah.
who has diabetes has hyperlipidemia, they are going to have this.
Yeah.
Always check their BMI. Very, very high. Okay.
Okay.
Not more than equal to, but this is a question where the patient's BMI was 36. Yeah. So that's very high. Right? This is a diagnosis of exclusion. When you don't have viral illness, when you are not alcoholic, when I have nothing, and on the imaging, I'm seeing that there is a hepatic steatosis, then I know it's alcohol, non-alcoholic fatty liver disease, right? When nothing is the answer, this is the answer.
Okay.
Treatment would be diet and exercise.
Yeah.
Okay.
Yes.
That's it. Okay. Then the next is hepatorenal syndrome. Now, because we have done this in renal, I'm not repeating it. Do you remember what hepatorenal syndrome is from renal?
Yeah, I think so.
You want to tell me?
Um,
Rough also.
yeah, it was when. Sorry.
Like rough idea will also work. If you just have a rough idea about what it is. Yeah.
I'm trying to remember. Um, I don't remember. Can you give me just a hint?
Yeah, sure. So see, hepatorenal, as the word suggests, there is a problem in the liver, and that is connected to the kidney. So let's start this way.
Yeah.
If the liver is not working, then what will happen?
Then there will be. Oh yeah, there will be reduced blood flow.
Yeah, you're going
Yeah.
in the right direction, but that is you're jumping to some step. What? How is there reduced blood flow?
Vasoconstriction.
Mm-hmm. I don't think you attended the live class, right?
No, I didn't.
Yeah, you do not.
But I'm still
No
trying to
worries.
remember.
Yeah, no worries. So hepatorenal, see, okay, let me just give you hints and you guide me further. So if the hepatorenal syndrome is the liver is not working, then one of the main function, which is metabolism of all the toxins, is not working, right? So what will happen? Toxins will
Yeah.
increase in the blood. What will these toxins do to blood vessels?
Constrict.
Mm-hmm. It will vasodilate.
Oh, dilate. They will
Yeah.
vasodilate. Yeah.
Because of this vasodilation, we have splanchnic vasodilation, right? And
Yeah.
because of that splanchnic vasodilation, you have third spacing.
Oh yeah.
Third
Then I
spacing.
remember. Then there's leakage
Yeah.
of fluid into the
Very good.
interstitium,
Very
which
good.
causes hypovolemia.
In
Yeah.
the body. Very good.
In the
Body
body.
thinks
Then
that low water. Okay. Then
and then RAS is activated, which causes
super.
vasoconstriction. Then reduction of EGFR and blood flow,
Very good. Very good.
which will cause it to have okay. I remember.
Acute kidney injury. Perfect. You got it, right? So main thing is the
Yeah.
toxins causes vasodilation that causes third spacing. So all the fluid is going in the
Yeah.
interstitium. So nothing in the blood vessels. So the body will start thinking that, okay, I don't have water. Kidneys will start producing more and more RAS. That is going to cause vasoconstriction and decrease the renal blood flow, which eventually decreases GFR and cause acute kidney injury.
And that
Why?
was the one that doesn't get better with fluids.
Exactly. That is the point. That is the main point. No improvement in the renal function with fluids. Perfect. You
Yeah.
just have to know this concept. Super. Great. So,
Yeah.
why this is important? Because if there is hypotension and that is causing AKI, we know that this is a pre-renal AKI, right?
Yeah.
It's a pre-renal
Yeah.
AKI, and we know that most common cause of pre-renal AKI is hypotension, and we give fluids for that, and the patient gets better. But after
Yeah.
doing that first step, if the patient is not getting better, then you always there has to be this bulb in your head, right? Which
Yeah.
should tell you that now it is cirrhosis, the only condition where there is going to be third spacing. That is cirrhosis, which is causing this. So no improvement in renal function means there is splanchnic vasodilation.
Yeah.
It's a fake hypotension. It's a fake hypertension. Yeah, you keep on giving more fluids, you are actually worsening the scenario. It's still going to get shifted in the interstitium, and the kidneys are not going to get anything.
Yeah.
All right.
Yeah.
Perfect. So that is hepatorenal syndrome.
Yeah.
All right. One-liner questions from this solid liver masses. If a patient has, for example, if a patient in the question has history of occipital use and has a solitary liver mass, what do you think is the mass?
It's a hepatic adenoma.
Oh, yes, hepatic adenoma. All right, so the occipital use in the question, it's hepatic adenoma. What if a patient has no history of occipital use, but the nodule that we have seen has a central scar and anomalous arteries?
Carcinoma?
Mhm. This is important, central scar.
Central. Um,
No?
I'm not sure. No.
Focal nodular hyperplasia. Okay?
Oh, okay.
Focal nodular hyperplasia. So occipital use, then hepatic adenoma, central scar, then focal nodular hyperplasia.
Hyperplasia.
Okay?
Yes.
For example, if a patient has fecal occult blood and has a single lesion in the liver, what is this?
Metastasis?
Wow, superb. Okay, it is metastasis. Now, why this is important? Because what we all, our mind always associates metastasis with what? Multiple lesions, right? Whenever you talk about
Yeah.
mets, it is always multiple. So this is a question where they give single. So it can be single or multiple, but yeah, you have to remember it can be single also. Okay, if it is single and fecal local blood is there indicating that there is colorectal cancer underneath, then the
Yeah.
answer is liver mets.
Okay.
Okay.
Yeah.
Right. Okay. Then coming to this topic, which is also easy. But before doing that, let me uh, tell you something basic. So bilirubin, right? We are doing a hyperbilirubinemia. Next. So in hyperbilirubinemia, first of all, let's establish. First of all, there is an RBC. Okay, RBC breakdown releases bilirubin, right? Bilirubin
Yeah.
can enter liver. Once it enters the liver, with the help of UDP glucuronosyl transferase enzyme, the unconjugated bilirubin gets converted to conjugated bilirubin, right? Once
Yeah.
unconjugated is indirect bilirubin, conjugated is the direct bilirubin. So once it gets converted to the conjugated, it goes out of the liver further. Now, let's do some
Yeah.
problems over here. So this bilirubin is still unconjugated, right? If a patient has a problem before entering the liver, means the patient has any hemoglobin problem.
Okay.
Wait, let me frame it well. If a patient has any problem, if a patient has hyperbilirubinemia, not any problem, hyperbilirubinemia, before entering the liver, um, I'm not framing it correctly. Wait. Give me a moment. Okay.
And
Okay, if a patient has hyperbilirubinemia, and then the next thing you have to check is whether it is conjugated or unconjugated. If it is unconjugated, it
yeah.
indicates that there is a problem before entering the liver. Yeah, now it is correct.
Yeah.
Yes.
Yeah.
Thanks for the patience. So, once it is unconjugated hyperbilirubinemia, you know there is problem before entering the liver. Once the hyperbilirubinemia is conjugated, means the problem is somewhere in the liver or after the liver, not any blood problem, right? Because now it's already conjugated.
Yeah.
So if that is high, means the problem is after liver or within the liver. Clear?
Okay. Yes.
Okay. Now, more microscopic view of this liver. So, if a patient has this UDP glucuronosyl transferase enzyme is there, but it is low. then what will happen if it is low? The unconjugated is going to be high compared to the conjugated. So this patient has Gilbert syndrome. Okay.
Yeah.
Gilbert is where the UDP glucuronosyl transferase is low. So the conversion is not happening and they are going to present with unconjugated hyperbilirubinemia. Because the production is only low and not it is entirely absent, these patients have presentation only during stressful situations, not in routine life. Only during stress, during illness, during physical exertion, they are going to turn yellow.
Okay.
Not in routine life. Okay. But if this enzyme is entirely absent, that condition is called Crigler-Najjar syndrome. Entirely absent, so now they are going to be yellow the whole time.
Yeah.
Okay.
Yes.
Then, if there is a problem, once this is converted to conjugated, there are two things. Conjugated is stored in a vesicle in the liver, and then it is transported out of the liver. So the place where it is stored, if that storage is not happening well, that is called rotor syndrome. And once storage is happening, means, for example, you can remember like this: the conjugated bilirubin is formed from unconjugated, conjugated is formed. It is usually stored in a car. Okay, it is stored. So storage is well, but that transportation is not well. This car is not moving further. Then that condition is called Dubin-Johnson syndrome.
Okay. So storage is done, but it's not.
Yes, but it's not getting transported ahead. Wait, wait. That is rotors. Okay, so UDP glucuronosyl transferase enzyme, if that is deficient, it is what condition?
If it's deficient, then Gilbert.
Okay, when it is absent, then what is it?
Then it was the Crigler-Najjar.
Yes. If there is problem in the storage of the conjugated bilirubin, then what is it?
There'll be rotor.
Very good. And if there is problem with the transport of the conjugated bilirubin to the
That's
border, that is
Dubin-Johnson.
perfect. Perfect. Got it?
Yeah. Yes.
I just have seen questions about Krigler, Gilbert syndrome most commonly and Krigler, not the other two. But you should have a brief idea, right? If they ever want to ask something.
Yeah.
All right. So this is just giving you a brief idea. Then we can solve this chart. So now, if a patient comes to you with hyperbilirubinemia, what is the first thing you want to check?
Check if it's conjugated or unconjugated.
Very good. If it is unconjugated, then it is either hemolysis, right? Or
Yeah.
there is some conjugation defect, which is Gilbert or Krigler-Najjar, right? Where it is not getting converted from this to this.
Yes.
So this, right? But
Yeah.
if it is conjugated, then next thing to check would be what?
If it's conjugated, then you check if it's the deficiency in, if it's either transport or um deficiency in, yeah, in packaging
Okay.
or
Okay.
you can also check other things, like if there's a problem with the liver.
Exactly. Very good. So
Yeah.
there are so many other problems, right, that can increase
Yeah.
conjugated hyperbilirubinemia. So what is the first baseline test that you want to do to differentiate whether the source is liver, whether the source is this congenital problem, or whether there is any pancreatic problem which is causing blockage and increase in conjugated? How would you differentiate that?
Let me do LFTs
Super.
and
Very good. Liver
lipase.
function test, right?
Yeah.
Liver enzyme function test is the first thing after after checking conjugated unconjugated. Now,
Yeah.
once you see the liver functions, either they are going to be very elevated, which is increased AST ALT, then you know the cause is within the liver, either viral hepatitis, alcoholic hepatitis, autoimmune hepatitis, non-alcoholic fatty liver disease, all the liver problems, ischemic hepatitis, right?
Yeah.
What if they are normal? If the LFTs are normal and there is conjugated hyperbilirubinemia, then it is either Roters or Dubin-Johnson, the hereditary hyperbilirubinemias. Okay.
Okay.
But if only in the LFTs you are doing, the AST, ALT is normal, but alkaline phosphatase is high, only alkaline phosphatase is high, then you know the problem is in the biliary tract. This is a marker for the biliary tract, right?
Yes.
So, biliary tract problems like primary biliary cirrhosis, primary sclerosing cholangitis, either a stone in the tract, malignancy of the tract, something of the biliary tract,
Yeah.
right? What would you do next to diagnose, to differentiate which problem, which biliary tract problem it is? What next test?
Is it the GGT?
Okay, super. Number one thing after the increased alkaline phosphatase is to confirm whether the problem is in the biliary tract or alkaline phosphatase also increases in bone problems, right? So the next test is to do
Yeah.
the GGT, gamma glutamyl transferase test, to differentiate whether the alkaline is high because of biliary or not. If that is also elevated, then what
Yeah.
else? What is the next step?
Maybe ultrasound?
Superb. Right upper quadrant ultrasound plus something else
Yeah.
also.
Mhm.
Anti-mitochondrial antibody. Okay.
Yeah.
So right upper quadrant ultrasound is done along with anti-mitochondrial antibody. So if that shows, if the AMA is positive or the ultrasound shows abnormal hepatic parenchyma, then you have to directly go for liver biopsy. Okay.
Okay. Okay. Yes.
If the ultrasound is going to show you dilated bile ducts, then you have to go for ERCP, because most commonly there is going to be a stone which is causing this
Mhm.
dilation. So you have to go for ERCP. If both are normal, then it can be, you can do anything that you want to find out the cause.
To either. Okay.
Yeah. But main is this, that if this is positive or abnormal parenchyma, then biopsy. If it shows dilated bile ducts, then the answer is ERCP. That is main. Clear?
Yeah. Makes sense. Okay.
So that is the whole chart of hyperbilirubinemia. First, conjugated, unconjugated. After establishing that LFT is high means liver is the problem. LFT is normal means hereditary problem. Then LFT is normal but ALT is high means biliary tract problem. Double check the biliary tract problem by doing a GGT. If that is also positive, then do an ultrasound and AMA to rule out whether there is a stone, whether there is a malignancy, what is it. So if the AMA is positive or the parenchyma is abnormal, means there is a good chance of malignancy, go for biopsy. If the USG just shows dilation, means there is a stone, go for ERCP.
Yeah.
Cool, got it?
Yeah.
Perfect, okay. Talking about this, okay, last is biliary atresia. So atresia, biliary atresia means that either the gallbladder is absolutely absent or there is a very shrunken small gallbladder, abnormal gallbladder. Okay, that is biliary atresia.
Mhm.
Atretic common bile duct, the common bile duct and the whole this bile system is not formed well. That is biliary atresia. So most common giveaway line for the presentation in this case is initially well appearing, then over 2 to 8 weeks has all these signs and symptoms, but initially well appearing, then degrading. So after 2 to 8 weeks, of course, because the bile system is not there, there's going to be pale stool, there's jaundice, hepatomegaly, hyperbilirubinemia. And yesterday I explained you, if there is any problem before liver, it's unconjugated hyperbilirubinemia. Any problem leaving after the liver, that is conjugated hyperbilirubinemia. So here you have conjugated increased bilirubin, right? Make sense?
Yeah.
Okay. Mild elevation of transaminases, all those things are common. The liver involvement is common. But main thing is initially well appearing and then deteriorating. When you do the ultrasound, this would usually be mentioned in the question, then only it's little understood. USG, when you do, there is absent or abnormal gallbladder. Okay. When you do liver biopsy, what you will see is, because this is not there, let me make it here. The gallbladder and the common bile duct is not there. What will happen? Because of the backflow, everything here in the liver starts getting affected. There is inflammation, fibrosis of all these intrahepatic ducts, and eventually all these portal tract edema and inflammation is going to cause fibrosis in the liver, because whatever it is producing, it is not going anywhere. There is nothing down there, right? So it's all backflow coming back, causing inflammation and fibrosis in the ducts and damaging the liver. So in them, the treatment is just one thing, that is liver transplant, or do a hepatoportoenterostomy, like just skipping this part and connecting it to somewhere in the gut.
Okay.
Okay. So this did you understand the how it is happening, what is happening? This part is not there,
Yes.
right?
Yeah.
So liver
So
biopsy
there's a
will
lot of
show.
backflow.
Hmm.
There's a lot of backflow, so the liver biopsy would show inflammation and fibrosis
Very
of the
good.
hepatic ducts.
Very good. So expanded portal tracts, inflammation,
Yeah.
fibrosis, all those things. That is also one
Yes.
UY question where the biopsy finding was, the findings are given in the options and you should know what it is, right? So expansion, inflammation, fibrosis.
Yeah.
Clear?
Yes.
Perfect.
Expansion of bile duct.
There are actually 3, 4, 5 questions on biliary atresia. Another one in simpler manner, they are asking what is the problem here? What is the pathophysio? And the answer line is decreased excretion of bilirubin. Oh, one of the option was what is the cause of jaundice? So the answer is decreased excretion of direct bilirubin. Yeah, because it is it is conjugated hyperbilirubinemia, which is another was
Yeah.
direct bilirubin.
Yeah.
So it's decreased excretion. Clear up to now?
Yeah.
Okay, this is a gynac topic, but it is extremely high yield, so I'm just quickly will revise it. What are the contraindications, absolute contraindications of breastfeeding?
Hmm. Contraindications.
In which patients you cannot go for breastfeeding? Any infections that you can think of?
Yeah. So I'm trying to remember now. If they have any like systemic infections.
Very good. What kind of systemic infection? Any sepsis or septic infection would be a contraindication?
No.
No, right? So some sexually transmitted infections.
Oh yeah, I remember
Yeah,
this. It was
yeah.
HIV.
Hmm.
Or there if there was any herpes, herpetic lesion.
Very good. Herpetic lesions, but particularly on breast. If it's anywhere else, it's not a contraindication. If it's
On
on breast, then only. Then,
any TB.
very good. Active TB, very good. Then,
Um, any chemotherapy, maybe?
very good. Superb. Chemotherapy or radiations, right? Then,
There was, I think it was varicella infection. If there's active varicella infection.
superb, superb, very good. Varicella infection in less than 5 days prior
Yeah.
to or within 2 days after delivery.
Yeah.
Then, one more is missing. Just one more.
Oh, IV drug use.
Superb, yes. IV drug users or alcohol abuse patients. Yeah.
Yeah.
So infections like HIV, herpes, TB, About the TB, if you have started them on anti-TB medication, then after 2 weeks of starting the therapy, you can still allow them to breastfeed. Okay. So
Okay.
active but untreated TB, you don't go for breastfeeding. Start the treatment after 2 weeks, you are allowed. Then chemotherapy or radiation, varicella infection, or IV drug uses. Clear?
Yeah. Perfect.
Next we have biliary cyst. Very common. Again, biliary cysts are of lot many types. For example, if this is the gallbladder, common bile duct, and these are the intrahepatic ducts. So biliary cysts are very common. There are a lot of types. If it is seen, if it is seen in the common bile duct, that is type 1. Type 2 is like an outpouching. Type 3 is like something at the opening. Type 4 would be intrahepatic duct involvement. Type 5 will be furthermore in. But again, we don't have to remember the types. I'm just giving you an idea that the cyst can be present at different locations. Most common type is the type 1, which is seen, which is a huge cyst in the common bile duct.
Okay.
This is the type 1, which is very common and of our concern. It's extrahepatic. It's a single cyst where there is a cystic dilation in the common bile duct. All right. So clinical feature. Again, there is a triad that we have to mark up here, but it's easy. So the triad is number one, there is a palpable mass. Makes sense because yes, I can see a cyst, so it's a palpable mass. Number two, because it is close to liver, it can have jaundice, compromise the liver, so jaundice. And lastly, there is pain. So pain, palpable mass in the right upper quadrant, and jaundice. That is biliary cyst.
Okay.
Okay.
Yeah. I think
Diagnostic. Hmm.
I had this question and I confused it for something else.
You confused it with
I think cholecystitis.
cholecystitis. Okay.
But in
Chole,
that you don't have a mass.
you don't have a mass, right? I was thinking that only.
Yeah, you don't.
Yeah, you don't have a mass, right? Plus, I don't think stones are that common in children. Stones are not there in children, I guess.
Yeah. Also the age. That makes
Yeah, yeah,
sense.
yeah. But it's, I know it's difficult when you do theory, it's completely different. But when you do MCQs, there's just
Yeah. It's like
it's
little
very
things.
difficult. Yeah. So palpable mass, pain, and jaundice. All right. And again, I think cholecystitis. So that should be postprandial most commonly. Like
Yeah.
the presentation, clinical symptoms should increase or aggravate after meals.
Yeah.
Anyways, we'll do that also. Okay. So diagnosis is visualization on ultrasonography, right? It's child, so you always prefer ultrasonography. When you do ultrasonography, you are going to see this extra hepatic cystic mass. Easy.
Hmm.
Treatment is going to be simple. Just go for surgical correction. Important is the complications. So complications of a single or whatever biliary cyst is cholangiocarcinoma. That is why you have to remove it to prevent the cholangiocarcinoma. Other complication is acute cholangitis. I'll tell you in more details what is cholangitis, pancreatitis, and stone formation. So there is because of this pancreatitis, there is one of the option is which is pancreatic pseudocyst.
Yeah.
Because in this question they had also mentioned increased amylase and increased lipase, just to confuse you. So now if you have increased amylase, increased lipase, and you have this triad, and you know that it is biliary cyst, but biliary cyst can also cause pancreatitis. And in that case, you have two options, biliary cyst or pancreatic pseudocyst. What would you go for?
Mm. Oh, good. Pancreatic cirrhosis, huh? Actually, no. It's biliary
Mhm.
cyst that's causing the pancreatitis.
But what is it right now? So pancreatic pseudocyst is there in the option.
It's not causing a pseudocyst. It's causing pancreatitis.
So that is pancreatic
Go
pseudocyst
with
is a complication of pancreatitis.
that's true. I don't know. I think I'll go with biliary cyst.
Yeah, that's actually safe. But yeah, it can be very confusing when you see the question because amylase and lipase is there. So directly you
Yeah.
like to go for pancreas as the answer. So just remember for this one, because it's confusing, pancreatic pseudocyst takes lot of time.
Yeah.
Yeah, pancreatic pseudocyst is going to take time, whereas this one, biliary cyst, it is going to take time. I mean, but it's not as long process as pancreatic pseudocyst, because pseudocyst, this has to happen, then pancreatitis has to happen, chronic pancreatitis itself takes time, and then pseudocyst has to happen. So it's a very very long process, whereas this biliary cyst, that is that it's not a long process. It is something most commonly it's going to be present since infancy.
Okay.
Most commonly it is diagnosed at the age less than 10 years. So it's never going to be pancreatic pseudocyst under age 10 years. Yeah, let me put it that way. That makes more sense. So this one most commonly less than 10 years, and you know pancreatic pseudocyst is not going to happen in 10 years. It's a very long
Yeah.
process. Okay.
Yeah. Makes sense.
So AMA and everything. So first is primary biliary cholangitis.
Mm-hmm.
There are two things: primary biliary cholangitis and primary sclerosing cholangitis. So remember, biliary is females,
Yeah.
and the other one, sclerosing, is in males. 99% it is going to be this only: female for biliary, males for sclerosing.
Okay.
So in the question, if the male female thing is given, and if you are getting at all confused between these two options, then you can trust the male female thing.
No. Okay.
Okay, so females is biliary. You can remember like this BV is female, right? So
Yeah.
yeah,
That's a good way to remember. Yeah.
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 So that is the females. Primary biliary cholangitis is females.
Okay.
All right. So this is something that is going to be common in females. It is autoimmune. The main problem is autoimmune destruction of the intrahepatic bile ducts. Okay.
Okay.
Pathophysio, intrahepatic destruction of the bile ducts, very common in females. The presentation is also like common things. If the biliary tract gets affected, there is going to be
Mm-hmm.
pruritus,
Yeah.
fatigue, that is eventually progress to liver problems. So jaundice, hepatomegaly, xanthelasma, steatorrhea, all those things, portal hypertension, blah blah blah. None, that is none of our concern. Main thing is AMA is going to be positive in this. Anti-mitochondrial antibodies positive. This is of course of our concern, but these are like common findings. It can be seen in all the biliary tract and liver problems. There is no point
Yeah.
remembering that, right? If AMA is positive, then you should know it is primary biliary cholangitis, something common in females.
Okay.
Treatment is give them orso deoxycholic acid from outside.
Okay.
Okay.
Yeah. That
Hmm.
makes.
Yeah, just give them this hydrophilic bile from outside. That is going to decrease the injury to the biliary tract and increase the biliary secretion. It is anti-inflammatory also, multiple uses. In short, remember UDCA for anti no for primary biliary cholangitis. Okay.
Okay. Yeah. Mostly it's females. That's how.
It's females, yes. Primary
The
sclerosing
female
cholangitis.
autoimmune.
Female what?
Yeah.
And
Because
autoimmune.
it's yeah. Yeah.
Yes, yes, yes. Then we have primary sclerosing. This is the one they are very interested in.
Mm-hmm.
Very, very high list. Primary sclerosing cholangitis. So number one thing I told you, it is common in males.
Yeah.
Other risk factors, tell me one risk factor for this one.
Ulcerative colitis.
Super, super. 90% of patients have ulcerative colitis underlying it as the cause, right? So it's very common. Mainly ulcerative colitis, all the signs and symptoms are given bloody diarrhea and blah blah blah. And one or two of this that the liver function test are elevated, then you should know that they are talking about primary sclerosing cholangitis.
Okay.
Okay, so diagnosis is going to be increased LFTs. Another thing is, tell me if two things are given in the options for the diagnostic test of this condition. You have ERCP or MRCP in the option, and you have liver biopsy in the option. What would you go for?
ERCP.
Why not biopsy?
Because it's also outside the hip. It's in the hepatic ducts, isn't it? And not
So
the liver.
this is a condition where this is, for example, the liver. This is the biliary tract. Okay, so this is a condition where this biliary tract is affected, plus the intrahepatic and the extrahepatic ducts are also involved, and there is that beading constriction and beading thing seen. What do you call
And
it?
then you would do biopsy.
Stricturing and dilation of the intra and extrahepatic bile ducts, which gives
Yeah.
that beading appearance. It's not written over here, but I know that there is that
Yeah.
beading thing. Hmm.
Yeah.
Yeah,
So then you would do biopsies.
that's what I thought, and I went for biopsy, but
But it's
but it's not biopsy. On the biopsy, so this is the beading thing that you see. That
yeah.
is something that you will see on the uh, cholangiography, and the liver biopsy is going to give you onion skin pattern, like where there is concentric pattern, onion skin appearance, where there are what do you call it, fibrous obliteration of small bile ducts with concentric replacement by connective tissue. Ha ha ha, nobody cares. Onion skin appearance, that's all we
Yeah,
have to
onions.
remember.
That's all I can remember.
Yeah. No, but actually it's easy only. They are just saying in a fancy long length line that when the small bile ducts are affected, what is happening? There is connective tissue round and round and round. Uh, like
Yeah.
there is a, yeah, there is a connective tissue surrounding that
Concentric.
small bile duct. That's all they are saying by this. Yeah,
Okay.
there's fibrous connective tissue around that small duct, which is causing this onion skin appearance, and you will see that beading appearance, also constriction, dilation, constriction, dilation. Now, why the
Yeah.
answer is not liver biopsy is, it is done. It can be done on the liver biopsy only. You are able to see these things, but that the biostat comes in the way. The specificity. Okay, so the next thing that we have to do is the cholelithiasis, the gallbladder and the pancreas, right?
Yeah.
All right. So starting with the easy one, that is cholelithiasis. Now, when the word cholelithiasis comes, there should be a image of the patient, how the patient is looking, age group, sex, and all those things. So, what do you know? Do you know? Do you remember anything about cholelithiasis?
It's the female 40,
Yes.
fertile,
Yes.
and fat.
Very good. So, female, age group around 40, fertile, and fatty, right? So
Yeah.
most common category for for the gallstones, right?
Yeah.
There can be three mechanisms how there can be gallstones. Starting with one which is very common, which is gallbladder stasis. Yeah.
Yeah.
All right. So number one is gallbladder stasis. What do you think can cause gallbladder stasis? Any idea?
There's a mass.
Okay, long shot. Hmm. This is a very common thing.
Oh,
So,
biliary strictures.
okay.
No.
You're right. I mean, biliary strictures, mass, anything over there can cause gallbladder stasis, which is true. But anything common, like if a patient is very commonly now that there is a trend of fasting. So if a patient is on prolonged fasting or total parenteral nutrition. Okay, a patient on TPN or doing prolonged fasting can have gallbladder stasis. So what happen can have gallbladder stones. So what is happening? Main thing, the basic mechanism that we have to remember is that what happens when you eat food. So once you eat food, there is something called cholecystokinin, right?
Mm-hmm.
The duodenum, it receives the food, you eat the food, it goes to the duodenum. The duodenum releases cholecystokinin. This cholecystokinin goes to the gallbladder and causes contraction of the gallbladder, which will release all the bile and the enzymes, right? So, if you are not eating stuff, you don't, the duodenum does not get food, the duodenum does not release the cholecystokinin, and there is no gallbladder contraction. So, there is stasis in the gallbladder. Make sense?
Yeah. Yeah.
So there is, because of no contraction over the time, there is sludge formation and gallstone formation out of that. So patient who are doing prolonged fasting or total parenteral nutrition, they are at risk for the gallstones. That is number one thing. Number two thing can be small bowel obstruction or Crohn's disease, which also can have this. So because of the small bowel obstruction, there can be ileal resection, which is also a small bowel problem disease.
Mm-hmm.
So most commonly the question can be if a patient underwent a Roux-en-Y surgery or any condition where the ileum is resected or has long-term ileal Crohn's disease. So the ileum is involved. Now what happens because of the ileum getting compromised? There is decreased enterohepatic circulation of the bile acids. Because of this altered no bile acid coming back in the circulation, the composition of the bile gets altered, and now there is just only cholesterol left in the bile. Because of lot of cholesterol, super saturated the bile with cholesterol, there are cholesterol gallstones formation. Okay,
Yeah.
you remember enterohepatic circulation, or should I go through that once quickly? We should do that.
Um, we can review it. Yeah.
Okay, so hemoglobin, number one. Hemoglobin is going to break down and release bilirubin, right?
Yeah.
Bilirubin conjugated to albumin. This is unconjugated at the moment, enters the liver, and in
Yeah.
the liver, now it is going to become conjugated. Once it is becoming conjugated, now it is released in the circulation, and it is, for example, going to the gut. Okay. Once it reaches the gut, what happens? There are bacteria in the gut lining which has beta glucuronidase enzyme. Beta glucuronidase enzyme breaks it down and makes it unconjugated again, makes conjugated to unconjugated. This is happening in the gut. This unconjugated again gets taken up in the circulation and gets back to the body and enters the liver. So this is called enterohepatic circulation. Enterohepatic circulation. Once conjugated, goes to the gut. Again, some part of it, not everything, of course, some part of it gets converted to unconjugated and enters the system again. The remaining
Yeah.
that is there, it is goes and becomes the urobilinogen and the stercobilinogen and those things. But some part gets back in the circulation. So in this case, where the ileum is not well, this enterohepatic, this taking it back in is not happening. So you don't get this bilirubin back in the circulation. So in the bile, the composition of bile has this all this bilirubin and cholesterol and everything together. So that composition is somehow, because of this thing, affected, and only cholesterol remains in the bile. So it is going to become super saturated with cholesterol and form cholesterol stones.
Okay.
Okay.
Yeah, makes sense. Yeah, makes sense.
So that is the second mechanism where the ileum is affected. And third is the pregnancy, the fertile stage. So in that fertile stage, what is happening? There is increased estrogen and there is increased progesterone. So progesterone causes gallbladder stasis. It slows it down.
Okay.
It slows it down, and the estrogen increases the cholesterol production. So both of that together forms
Mm-hmm.
stones, right? Gallbladder stasis
Yeah.
and increased cholesterol, perfect recipe for stones.
Yeah.
So these are the most common three mechanisms which are asked. So how do you manage gallbladder stones if a patient has stones but no symptoms? Like it was an incidental finding on USG, you saw that there are stones. How do you manage it?
I think you just reassure.
So if you know that the patient has gallstones, you don't do anything.
I think you remove them, but I don't know if you remove it right urgently or you scheduled cholecystectomy.
Okay. So number one thing, if I was just confusing you, gallstones without symptoms. If you don't have signs and symptoms, then don't do anything. Just reassure.
What I said.
You don't, no treatment necessary in most of the patients. You don't treat them. Okay, even if you see stones, you don't treat them. Only if a patient has gallstones with like typical signs and symptoms, typical biliary colic signs and symptoms, then of course you schedule the cholecystectomy and you have to remove it. Elective laparoscopic cholecystectomy has to be done, but only if there are signs and symptoms. And lastly, if there is complicated gallstones, complicated means acute cholecystitis like severe pain, perforation, or fistula formation, those kind of things, then you have to do very like urgently and schedule in less than 72 hours and remove it.
Yeah.
Okay.
Yes.
Perfect. So main question, they are not concerned about these two because they know that everybody is going to go for cholecystectomy. They are going to ask this, that if you don't have signs and symptoms and see gallstones, then answer is reassurance.
Yeah. Makes
Okay.
sense.
Yes. Then you have cholecystitis and cholangitis. So let's differentiate first of all what are these two things. Okay. Cholecystitis is any problem in this part, gallbladder and the cystic duct. Okay, only the cystic duct, that is cholecystitis.
Yeah.
If there is problem in the common bile duct, which is this, it becomes cholangitis. Clear?
Yeah.
So only problem in this gallbladder duct, which is cystic duct, that is cholecystitis, and problem in the common bile duct, that is cholangitis. Now, most common presentation or question is acute cholecystitis, which is inflammation of this duct. So most common cause of that is going to be what? There are stones in the gallbladder.
Oh,
Patient
yeah.
is eating, food comes in, duodenum secretes cholecystokinin that goes to the gallbladder, contracts it, and these stones they pass through this canal and obstruct it, which causes infection, inflammation, and pain after meals. Right?
Yeah. Yeah.
So always in the question there is going to be postprandial abdominal pain, postprandial right upper quadrant, or epigastric pain. Okay.
Yeah.
But because it is acute, remember this is the difference. If it is acute, it is not necessary that the alkaline phosphatase and GGT, they are the markers for the biliary tract, right? So in
Yeah.
acute cholecystitis, it is not necessary that the alkaline phosphatase is going to be high. So sometimes they can give it normal in the question just to confuse you, but you should know that after postprandial, this right upper
Yeah.
quadrant pain and no other diagnosis, then you have to go for acute cholecystitis.
Okay. Makes sense.
Okay. Alkaline phosphatase can be normal because it's acute in initial stages. It is not always increased um, in early phases. It can be normal. All right.
Yeah.
How do you differentiate this with there is something called acalculous cholecystitis that is also very high. This is because of a stone. This cholecystitis is because of stone. There is something called acalculous. Without stone, there is cholecystitis. Any idea what can be the cause?
Isn't that when there's necrosis? From an
Okay.
the because I remember if someone's like it's after a recent illness, someone's in
Very
ICU,
good. Mhm.
um, that can cause it to have maybe the infection leads to like necrosis of the gallbladder.
I mean, yeah, okay, eventually it can. So very good. That is very, very high. Most common cause is one you said long-term infection or a very severe infection, sepsis, or patient has critical illness, right? Or has trauma, burns, any surgery, right? So most common are these causes that can cause acute cholecystitis. Clinical presentation wise, again, it's going to be same, right upper quadrant, vague abdominal discomfort, not postprandial specifically, but it can be vague, just dull, constant right upper quadrant pain. There can be fever because of the illness or infection, and leukocytosis because of the same reason.
Mm-hmm.
Okay, and abnormal LFTs and everything. Diagnostic test is also right. This USG. Okay. Now, if you
Yeah.
don't see, for example, right now in this question that we are discussing, we know that it is acalculous. But usually, when you have polycystic pain, the first thing you do is an USG, right, to check for the stones. If you don't see
Yeah.
the stones on USG, is there any other test that you do?
CT.
Okay. Anything other than that, particularly?
ERCP.
No.
If you don't see the stones.
If you don't see the stones, and you want to do something else.
Oh, okay.
Yeah. HIDA scan cholecystography, in other words, is always used to confirm that there are no stones or when the ultrasound is not diagnostic of the cause. Okay, so always you remember going for HIDA scan. And
Mm-hmm.
another giveaway in the question for our acalculous cholecystitis is pericholecystic fluid. There is fluid around the gallbladder and the duct.
Okay.
When you see this word in the question, you should know it is acalculous cholecystitis, pericholecystic fluid. Because of the
Mm-hmm.
inflammation, infection, whatever is the cause, there is fluid accumulation around the cystic duct. All right.
Okay.
And like you mentioned, because of this, all things, there can be eventually necrosis, ischemia, and that can cause distension and necrosis, and other like further bacterial infection and gangrene, perforation, emphysematous cholecystitis, and whatnot things.
Okay.
Okay. Pericholecystic fluid is also high. And third is the emphysematous cholecystitis. There are three types. So acute we did, then this acalculous we did, and then we have emphysematous cholecystitis. So it's easy. Emphysematous means there is going to be air, right? So most common risk factors for emphysematous is anything that causes vascular compromise. So one of the cause of this is the acalculous cholecystitis, these three things. And after that, we have diabetes mellitus. Diabetes also causes immunosuppression, and immunosuppression also causes emphysematous cholecystitis. So,
Mm-hmm.
because the word suggests emphysematous, so there is going to be crepitus in this right upper quadrant. That you, if you hear it, there is going to be crepitus. There is going to be air fluid levels in the gallbladder if you see it on an ultrasound. Okay, so this is just producing bacteria invading the gallbladder, gas forming bacteria invading the gallbladder and producing air. So you have air fluid levels. But anyways, it's easy because once you see air anywhere in the question, you should know it is emphysematous, right?
Yeah.
So it's easy other differentiating the others with this one. Treatment is just go for emergent lap cholecystectomy, remove it right away, and give broad spectrum antibiotic for the gas producing organisms like Clostridium and everything. So give Amsulbactam for the coverage of those organisms.
Okay.
Okay, but majority questions are on what is it. Then we have acute cholangitis. Like I told you, cholangitis is the inflammation of the common bile duct, right? So there is a classic triad and pentad, if you know.
Yeah.
You, can you tell me what is a triad for cholangitis?
The triad is fever, right upper quadrant, pain, and jaundice.
Very good. And what is a pentad?
The pentad is it gets worse, so you add the altered mental status and shock,
Shock. So hypotension, right?
hypertension.
Yes. So this is the Charcot triad. Charcot triad, and this is addition of these two is the Reynolds pentad.
Yeah.
Okay. Anyway, so lot of questions on acute cholangitis, but again, because of the triad and the pentad, our work is very easy in those cases when you have increased alkaline phosphatase, a marker for biliary tract, increased GGT, and increase in this LFTs, and then you check the triad and the pentad, and you know the answer is acute cholangitis. It's simple, right?
Yeah.
And again, there can be leukocytosis, there can be increased CRP, but those are all because of the infection, the inflammation. Not infection, but inflammation, right?
Yeah.
Treatment is, what is the treatment for this one?
Um, Antibiotics.
Okay, very good. Other than that,
And then they call it.
do ERCP, okay, with sphincterotomy. Just go
Yeah.
in there. It is both diagnostic and treatment. So ERCP, just go in there, open it up, and do a sphincterotomy right away. Or you can also go percutaneous transhepatic cholangiography, but always ERCP is in the options usually. So we'll go for that. And then the treatment is along with that, you have to add antibiotics. That's easy, right? But majority,
Yeah.
all the questions are about what is it, the diagnosis, and the answer is acute cholangitis. You should remember the triad, the pentad, alkaline phosphatase, and GGD, right?
Okay. Yeah.
Okay. Then is acute pancreatitis. Now this is very easy. Just have to remember 2 to 3 things for this. Pancreatitis, number one thing, what are the causes? Number one cause.
Yeah. Gallstones.
That is number two cause.
Idiopathic.
No.
Um, Alcohol.
Super. Chronic alcohol use is the number one cause for acute pancreatitis. Then number three cause is what?
Alcohol, gallstones, then trauma.
Okay.
There's uh, steroids.
Mm-hmm. Then.
ERCP.
Yeah. Okay. Then these are all the causes, but they are
Yeah.
not in the top three.
Any drugs?
There is also a cause, but not in top three. Triglycerides,
Oh,
right?
yeah.
I'm sure you know it, but you'll see it in the options and you'll get it, right? So number one is alcohol, that is high yield gallstones, triglycerides. Then the other things, you know, infections, trauma, post ERCP, that is all there. Then what is the diagnostic or clinical presentation? There is a diagnostic criteria. You need to have two of these things out of these three. So what are the three things?
There's the epigastric pain that radiates to the back.
Superb. Number one is radiating to the back. Perfect.
And raised amylase and lipase.
Very good. Amylase, lipase, very, very high. Then amylase to lipase ratio is actually more than 3 times than normal. Right? Yeah, so amylase is very, very high. Then
And then um,
imaging.
nausea, vomit, imaging.
Yeah, if you see it, if you do an abdominal imaging, it is going to show the enlargement, the enhancement on the CT scan or diffusely enlarged hypoechoic pancreas on an ultrasound. So ultrasound is going to show hypoechoic, diffusely enlarged pancreas, and CT is going to show that only enlargement, but heterogeneous enlargement.
Okay.
No, nobody's going to ask you detail hypoechoic, heterogeneous, those things. But main thing is the enlarged pancreas, right?
Yeah.
So pain radiating to back, high amylase lipase, and imaging showing abnormal pancreas. That is the main thing.
Yeah.
All right. Then this was pancreatitis. So three things are this. Other than that, causes of acute pancreatitis because of secondary cause, secondary to atheroembolism is also a very common question. Atheroembolism, but easy. Why? Because atheroembolism means cholesterol. So somehow one of this embolus is released, it goes and blocks the pancreatic blood supply, and that causes ischemic pancreatitis or acute pancreatitis. So what is going to be the presentation whenever you see a cholesterol emboli? How is the presentation of the patient? Along with the pancreatic enzymes elevated and stuff, cholesterol is there, cholesterol emboli is there. So what would be the manifestations?
Cholesterol. So you have raised lipid profile.
Okay. For example, most common question would be if a patient was undergoing any cardiac procedure, okay, and has atheroembolism. So suddenly after the cardiac procedure, the transaminases, the so not transaminases, sorry, the amylase lipase is high, and there is abdominal pain radiating to the back. What are the other findings that can be seen in this patient? So cholesterol emboli. Remember the skin changes I told you? What are the skin changes?
Yeah, there is one that are on your eyelids, I think.
Okay, that is the just indication of hyperlipidemia, the xanthelasma. This is the blue toe syndrome, remember?
Oh yeah.
Blue toe.
Yeah.
Yeah. So lipido reticularis, which is the skin changes, reticulated, mottled, discolored skin, and blue toe
Yeah.
syndrome.
I remember.
Remember? Okay. So whenever you see these things, you should know it is cholesterol emboli or embolism. Okay. So skin manifestations will be seen along with all the pancreatic thing, and there can be kidney damage, GI, and all those things. So that is an indication that the procedure triggered a emboli in the body. What is the treatment for this type of acute pancreatitis?
We try to control the cholesterol.
Yeah, very good. So main thing is, of course, you have to go for lifestyle modification, trying to control the cholesterol, but supportive treatment. You cannot do anything else.
IV
Right?
fluids.
Yeah, just IV fluids. Very good. So that is a UL question. That what to do in this case in acute pancreatitis because of atheroembolism? Answer is just IV fluids, supportive care. Okay. And you also mentioned one of the cause of pancreatitis as drug induced. So do you know what drugs? There is a list of drugs. I don't remember any of those because then nothing is asked. Only one very high yield drug I have to remember.
Yeah.
That is what?
Is it valproic?
Very good. Valproic acid. Super. Okay, so valproic acid we have to remember causes pancreatitis.
Yeah.
What are the other side effects of valproic? Can you tell me?
Valproic, it was teratogenic.
Hmm.
What else was it? Teratogenic, pancreatitis,
Mm-hmm.
hepatitis.
Yeah.
And then agranulocytosis,
Superb. Very good. Very high.
alopecia.
Alopecia. Perfect. Perfect. You covered all the major ones. Alopecia, hepatotoxic, and pancreatitis, teratogenic, agranulocytosis. Perfect. Perfect. Done. Then you have chronic pancreatitis. One is acute. This is chronic.
Yeah.
So chronic, most common cause is what?
Alcohol.
Very good. Number one is alcohol. Long-term chronic alcoholic. Second, what is the most common cause of chronic pancreatitis in children?
Cystic fibrosis.
Superb. Very good. Cystic fibrosis. Very good. Then there can be stones, malignancies, autoimmune, blah, blah, blah. But main thing is alcohol and cystic fibrosis that causes chronic pancreatitis. How is the clinical presentation?
You have like malabsorption,
Mm-hmm.
diabetes.
Very good. So pancreas is damaged. So number one
Yeah.
is malabsorption, right? You will have malabsorption. You don't have the digestive enzymes. Number two is going to be diabetes mellitus. Very good, because the beta islet cells are affected, right?
Yeah.
Then one more is chronic epigastric pain with intermittent pain-free intervals. I'll tell you why this is like this. Chronic epigastric pain with pain-free intervals. So most commonly there is going to be postprandial pain and postprandial watery, foul-smelling diarrhea. This is all there postprandial, because nobody's again going to ask you. This is something that I had to Google to, because I wanted to understand. That is because of chronic pancreatitis. What happens? The islet cells and the SNR cells, whatever, gets damaged in the pancreas.
Yeah.
Okay. Now, once the pancreatic exocrine functions are damaged, it used to release one enzyme, some enzyme, random, which breaks down the cholecystokinin. You remember cholecystokinin, which compresses the gallbladder,
Yeah.
contracts the gallbladder, right? So
Yeah.
this is an enzyme which is released by the pancreas, which usually breaks down the cholecystokinin once its work is finished. Because the pancreas is not working well, there is nothing which is breaking down the cholecystokinin. So now we have just a lot of unnecessary cholecystokinin, which keeps on hyperstimulating the gallbladder and keeps on compressing it and causes ischemia, inflammation, and this postprandial continued pain.
Okay.
Okay.
Yeah.
Don't have to remember the mechanism. It is just for our knowledge that there is an enzyme which breaks down the cholecystokinin. Now that enzyme is not there, so we have a lot of uncontrolled action of cholecystokinin, which is causing this postprandial specific pain. Otherwise, what is the relation of, like, there should not be this pancreatitis should not have postprandial pain, no?
Yeah.
But because of this unregulated CCK, we have postprandial diarrhea and postprandial pain.
Okay.
Okay. So these are the three presentation: a new onset diabetes and this malabsorption. Then what are the laboratory findings? So this is not like acute pancreatitis. Amylase and lipase, it can be normal also. It can be normal to high, but not like acute that it is, sharp high.
Yeah.
And on the CT scan or the MRI, if you do, number one thing, in any chronic condition, one thing that you see is always calcification.
Calcification.
Yeah. We saw this in chronic mesenteric ischemia also. The blood vessels were calcified, right? So here also we have calcification, a giveaway for this one. Pancreatic atrophy and calcification. And treatment. So what should be the treatment?
Giving the pancreatic enzymes.
Superb. That is, you give them enzymes from outside. Pancreatic enzyme supplementation. Okay. And one of the complications of this pancreatitis is going to be the pancreatic cyst. So always you have to keep an eye on the cyst. If for example, a patient already developed cyst, the few things that that this cyst can turn into a malignancy. So you should check is number one, the size. If there is a large size cyst more than equal to 3 centimeter, means there is a risk for malignancy. Number two, if there is any solid component or calcification, then you have to be careful. Number three, if there is pancreatic duct involvement, main pancreatic duct involvement, means it is spreading up. Involvement, ductal dilation, then, and last, thickened or irregular cyst wall. In these cases, if the question has any of this, which is a UL question, then the next step is how to keep an eye on them. Is if you think that there is risk of malignancy, you go for endoscopic USG guided biopsy. But if none of these features are there, but there is a cyst, then you just go for surveillance imaging. If it is benign, then just surveillance imaging. If one of these factors are there, then you have
Yeah.
to go for biopsy. That's your word. Okay.
Okay. Yeah.
So that is pancreatitis. Okay. And last from this is the pancreatic cancer, cholangiocarcinoma, and HCC. Let's differentiate these three.
Mhm.
Okay. Let's do the easy one, HCC, and get it out. So we just have to remember the markers which indicate HCC. So do you know other than AF? Okay, what will be AFP, and what will be the CEA or CA 19 level in HCC?
Hmm. And it's C. AFP will be raised,
Hmm.
and CAC19 will be normal.
Very good. It is normal. You're right. Okay.
Yeah.
So that is HCC. If I
Yeah.
say pancreatic cancer, what should be the AFP, and what is the CA 19?
AFP would be raised,
It's
and
normal.
also C. Oh, it's normal.
So
They're both
marker
normal.
for no. CA 19 is the
Yeah.
marker for pancreatic cancer. Okay.
Oh yeah.
AFP is the marker for HCC. Okay.
Yeah.
Confusion
I
comes when
got
you
confused.
have cholangiocarcinoma, because
Yeah.
cholangiocarcinoma also has normal AFP but a high CA 19, just like pancreatic cancer.
Yeah.
And the location of both. So this is liver, this is the common bile duct, and then this is the pancreas. So if you have a pancreatic cancer and you have a cholangiocarcinoma, both can increase the alkaline phosphatase, right? Because even this can back pressure cause biliary problems. So alkaline phosphatase GGT can be high, and
Yeah.
there can be palpable mass, right upper quadrant, or whatever location. So very similar looking. If they want to confuse you, they can easily confuse you.
Yeah.
So one thing used to differentiate these two is when you do a USG, when you have intrahepatic duct involvement or dilation,
Okay.
that is going to be because of the cholangiocarcinoma, because it's closer to the liver, right?
Yeah.
So when you have intrahepatic or common bile duct dilation, depending on whatever level of obstruction it is, the answer will turn to cholangiocarcinoma. If the liver is normal, then the answer is pancreatic cancer. That's the only difference. This is a UR question where all these markers are given. And
Yeah.
if you remember the markers, then you know that it is common in both. Check the USG in the question. The USG showed intrahepatic duct dilation.
Okay.
Okay. For pancreatic cancer, there is always going to be duct dilation, but the common duct dilation, this one, not the intrahepatic.
Yeah. Liver would be normal.
Yes. Makes sense, right?
Yeah. Yeah. Yes.
Here, common duct is dilated, plus intrahepatic ducts are also dilated. Clear?
Yes. Yes.
All right. So with that, we end the
So
thing.
well, I
Yeah,
can see
just
the notes. I don't see anything on the note. But...
Yeah, even I cannot see it, so you're not alone in that. Can you
Mhm.
see it now?
Yeah.
Hang on. Okay. So, Rowen, gastric bypass complications? Number one, easy. It's a surgery. So, what can happen soon after the surgery? There can be an anastomotic leak. You can see what I'm
Yeah.
writing or not.
Yeah, I can see.
Okay. So, post bariatric surgery anastomotic leak, there is a breakdown of that surgical anastomosis at that area, and it is very common in the first week of the surgery, soon after the surgery.
Mm-hmm.
And of course, there is a leak, so there can be infection after that. So, most common presentation is fever, abdominal pain, tachycardia, tachypnea, proper signs and symptoms of infection. Okay, heart rate more than
Yeah.
120, classic giveaway for underlying infection. So in that case, the question is about what to do next. So if a patient has this surgery and now has this complication, the next thing I want to check in first week, I want to do oral contrast enhanced CT scan to check where the leak is, because I know it is leak. In first week, if something can happen, that's a leak. So I want to do oral contrast enhanced abdominal CT scan to exactly catch the leak, and treatment is urgent surgical repair.
Yeah.
So this is easy, right? You just have to remember first week there is going to be leak. If a patient after the bariatric surgery comes, for example, after months or even uh, maybe yeah months only, 12 months, 14 months, like second year of surgery, that is going to be
Mm-hmm.
stromal complication, or you can also call it anastomotic stenosis, right? Because of the scar, now that area has undergone stenosis.
Yeah.
A long term complication of any kind of surgery, I would say, is stenosis. So here
Yeah.
there is going to be narrowing of that area, and in this one there is going to be presentation wise, there is no fever or there is no infection, this is just stenosis, so it's like an outlet obstruction thing, right? So you
Mm-hmm.
will have postprandial vomiting because nothing is going forward. You can have GERD like signs and symptoms again because of the regurgitation. Dysphagia, you don't feel like eating, it is not going
Mm-hmm.
down, and nausea and stuff. But main thing is the postprandial vomiting. Makes sense because there is an obstruction, right?
Yes.
So here the diagnostic test that you have to do is directly visualize it via an esophago gastroduodenoscope. So that is you will. When there is stenosis, you directly just want to go in and check what is happening. And when once you go in with the scope, you can also do balloon dilation to just treat it at that point. And in anastomotic leak, you wanted to find out the location of the leak, so you were going for contrast enhanced CT scan.
Yeah. Makes sense.
Okay, so both of these complications are UVL. First week leak, second, I mean not second week, but over the time
Long term.
there can be stenosis.
Yes. Makes sense.
Okay, one more short topic, that is sliding hiatal hernia.
Mm-hmm.
Do you know what is the treatment of asymptomatic patient in sliding hiatal hernia?
I think reassurance, isn't it?
Yeah, right, right. I was actually surprised by that. And now that in the rotations, I see so many patients who have sliding hiatal hernia. They do have like GERD signs and symptoms, obviously. But
Yeah.
again, if it's not bothering them, you don't do anything. Just reassurance
Yeah.
and observation. And if they have GERD signs and symptoms and PPIs, that's all. It's most commonly an incidental finding, and
Yeah.
main thing is the retrocardiac opacity, right? Always in the
Yeah.
question, retrocardiac opacity. So that's hiatal hernia. You don't do anything. So I'm not writing it. That's it. That's all we had to
Yeah.
do. Yeah. I think that's it. Main was this,
So we're done.
and we are done. We are done. Oh my god. Oh my god. Yeah, we are
Yeah.
done.
Finally.
Great.
But
Finally. Thanks, Varda, for
yeah.
sticking with me.
No, of course not. Of course.
Thank you.
But if I if I do have any questions or any review
Anytime.
topics, can I let you know?
Yeah, of course. Are you kidding me? Anytime.
Yeah.
Anytime.
Yeah.
Anytime. We'll schedule a call and then I can definitely explain those things to you again whenever
Yeah.
you know
Thank
we
you.
want to. Anytime.
Yeah.
Okay.
I,
I'm
I
also planning for just a 1 hour session for biostat, but I'll
yeah.
update you when to keep it. Okay. I'll ask you whatever time it's convenient to you.
Yeah. That would be very helpful. Yes.
Yes. Okay.
Yeah.
Because even
Thank you
my
so much, Renette. So it's a lot of help for me, and we'll be in touch.
of course, I'll not let you forget me. Don't worry.
Yeah. But I'll be in touch with you. No
Yes. Thank
problem.
you. I'm gonna
Yes.
miss you.
I know, me too. But we'll see each other in
Yeah,
statistics.
yeah, yeah. Right, right.
Okay.
We'll see each other.
Okay.
Okay.
Thank you.
Bye bye. Take care.
Bye
Have
bye.
fun. Have fun.
Thank you.
Enjoy. Bye bye.
You
Study well.
too. Bye bye. Thank you.